Welcome to week 2. This week we're exploring how technology can augment our needs assessment process, and we begin with digital epidemiology, a field that's transforming how we understand population health. Traditional surveillance methods, surveys, vital statistics, case reports remain essential, but digital data sources offer something new: speed, scale, and sometimes insights we couldn't get any other way. Let's explore what this means for public health practice. By the end of this lesson, you'll accomplish 3 objectives. First, you'll define digital epidemiology and understand its applications in public health practice. This is a rapidly evolving field, and understanding its scope is essential. Second, you'll compare traditional and digital surveillance data sources. Each has strengths and limitations, and effective practitioners use both. And third, you'll evaluate the validity and reliability of digital health data. Not all data is created equal, and critical assessment skills are essential. So, what exactly is digital epidemiology? It's the use of digital data for epidemiological research and surveillance. The key distinction is that this data is generated outside the traditional health system. It's not medical records or death certificates or hospital discharge data. Instead, it's the digital exhaust of daily life. Search queries: what are people looking for? Social media posts: what are people talking about? Mobile device data: where are people going? Wearable devices: how are people moving, sleeping? What are their vital signs? You'll sometimes see this called infodemiology or infovalence. The terminology is less important than the concept. We can learn about population health from data that wasn't collected for health purposes. Before we get too excited about digital data, let's appreciate traditional surveillance. It remains the gold standard for good reasons. Population surveys like BRFSS, the Behavioral Risk Factor Surveillance System, and NHANES provide standardized data collected systematically across populations. Vital statistics give us birth and death records, essential for understanding population dynamics. Notifiable disease reporting ensures we track important conditions. These traditional sources have real strengths. They're standardized so we can compare across time and place. They're validated. We know what the questions mean. And they use representative sampling so we can generalize to populations. Digital data often lacks these properties. But traditional surveillance has limitations too. Time lag is significant. By the time survey data is collected, cleaned, analyzed, and released, it may be months or even years old. You might be planning a program based on data that no longer reflects current reality. Geographic limitations matter. National surveys may not represent conditions in your specific community. Smaller jurisdictions often lack sufficient sample sizes. Cost is real. Conducting surveys requires significant resources. Not every health department can afford the data it needs, and fixed questionnaires mean we may miss emerging issues. If something new arises, a novel health threat, a new behavior pattern, it might not show up until the next survey cycle. This is where digital data shines. Speed: digital data can be available in near real time. Search trends update daily. Social media posts are timestamped to the minute. Emergency department visit data can be available within hours. This enables rapid response. Scale: the volume is enormous. Millions of data points are generated continuously. Every search query, every social media post, every movement tracked by a phone. This scale can reveal patterns invisible in smaller samples. Geographic specificity: many digital data sources can be localized. Search trends for a specific city. Social media posts geotagged to a neighborhood. This helps address the geographic limitation of national surveys. And digital data captures things traditional surveys don't ask about: emerging concerns, novel behaviors, real-time reactions to events. Let me walk you through the main types of digital data sources. Search query data reveals what people are looking for. When searches for flu symptoms spike in a region, it may indicate an outbreak. When searches for mental health resources increase, it signals distress. Social media shows what people are discussing and sharing. Sentiment analysis can track public mood. Topic modeling can identify emerging concerns. Electronic health records, while technically within the health system, provide digital data at unprecedented scale. Real-time syndromic surveillance from emergency department visits can detect outbreaks faster than traditional reporting, and mobile and sensor data from phones from wearables captures location, movement patterns, even physiological measures. Each source has different strengths and limitations, and different ethical considerations. Now for the critical assessment, we must ask validity questions. Does the digital signal actually measure what we think it measures? If searches for flu symptoms increase, does that mean more people have the flu? Or does it mean there's a new story about flu that's making healthy people search? The correlation with actual health outcomes is not always clear. Validation studies are essential before relying on digital data for decision making. Another concern, algorithms change. When a search engine updates how it autocompletes queries, the search data changes, even if nothing changed in the population. When a social media platform changes its algorithm, what content is visible shifts, and the population using digital tools may not be representative. Internet access, smartphone ownership, social media use, these are not evenly distributed. Digital data may systematically miss certain populations. Reliability concerns are equally important. Is the measurement consistent over time and place? Platform changes can disrupt data continuity. If a social media platform changes how it categorizes content, your historical comparison may be meaningless. Data access is a real issue. Platforms may restrict access to data that was previously available. They may discontinue data products entirely. Building your surveillance system on proprietary data creates dependency and risk, and proprietary data limits reproducibility. When researchers can't access the same data you used, they can't verify your findings. This is a significant limitation for scientific credibility. The bottom line, digital data offers exciting possibilities, but rigorous evaluation of validity and reliability is non-negotiable. The most effective approach combines fast and slow data. Fast data from digital sources provides rapid signal detection. It's the early warning system. Something might be happening. Let's pay attention. Slow data from traditional sources provides confirmation and context. Yes, something is happening. Here's how big it is. Here's who's affected. Here's what it means. Neither replaces the other. They work together. Here's an example. Search trends for a specific symptom spike in a region. That's your fast data signal. Something might be happening. You then look at emergency department syndromic surveillance data. Slightly slower but more specific. If that confirms the pattern, you investigate further. Traditional epidemiological investigation provides the complete picture. The search trend didn't replace the investigation, it accelerated it by alerting you earlier. Let's summarize our key takeaways. Digital epidemiology uses data generated outside traditional health systems, search queries, social media, mobile data, to understand population health. Digital data offers speed, scale, and geographic specificity that traditional surveillance often cannot match. But traditional surveillance remains essential. It provides the validity and representativeness that digital data often lacks. Critical evaluation is non-negotiable. Before relying on digital data, we must assess whether it actually measures what we think it measures, and whether that measurement is consistent. And best practice combines both approaches: fast digital data for early signal detection, slow traditional data for confirmation and context. In our next lesson, we'll explore how artificial intelligence can help us make sense of the overwhelming amount of information available to health planners. Thank you.